what psychopathology paradigm can best facilitate discovery of etiology and effective treatment. And we've been organizing a paper with some great people, Carl Friston in the UK, people like Deanna Barch are joining this paper, a lot of other people. We asked Josh Gordon from NIMH to join this paper. I'm not sure he will, but several people are joining this effort to really have this conversation about what paradigm is going to lead to the most discovery, the most advances in treatment. And so this is something we've been debating for a long time. Roman and I have worked a lot on nosology and what phenotype is best for thinking about psychopathology. That's really important work. Happy to come back and talk about that in more depth another time. That's not what this talk is about. This talk is about which paradigm is really going to lead us towards discovery, one focused on the brain or one focused on behavior. And I'll talk more about that. There are two kind of aspects of this that for me really stand out. The first is just how important this topic is. The burden of mental health is enormous. I don't think I have to tell most people in this room or in the audience that it strikes people during their most productive years. And if you think about different parts of medicine, when I was born, AIDS hadn't existed yet, and it came on the scene. It was horrific. And in my lifetime, we've made enormous progress in understanding and treating conditions like that. Psychopathology in my lifetime, someone with schizophrenia faced a 2-decade decline in life expectancy. That's enormous. People with bipolar disorder, a decade. These are really, difficult and disabling conditions. And I'd hate to say it, but in my lifetime, we haven't made the progress we want. Those statistics, unfortunately, haven't nudged as much as we want. And there's evidence that rates of suicide are going up, anxiety is level. So we have not made the progress that we really need to be making in thinking about psychopathology and treating it. The second aspect that just personally fascinates me is how this debate in psychiatry of where do you go, what do you study in order to make advances in psychopathology has been a debate that's been around in psychiatry for more than 100 years. Geisinger, who was in Germany, really a lion in terms of developing psychiatry, said we have to get out of the clinic and study brain tissue. We need microscopes. We need to look at brain pathology. That's where we're going to find mental illness. And people like Kreplin, who said brain researchers had, blazed a trail into neuropathology, but they never found their way back to psychopathology. Yes, studying the brain absolutely leads to advances, but there's this massive undifferentiated psychopathology that remains untreated and ununderstood if you just focus on the brain. And this, psychiatry as a result has been a little bit of a victim of its success because in psychiatry, once we discover the cause of something like syphilis and paresis, you take it away from psychiatry and it becomes, another part of medicine. And so psychiatry is left with all these conditions that don't have clear etiologies. Okay, so today we're going to talk about brain disorders and behavior disorders. Roman's going to go over some of the evidence. I'm going to talk about some evidence for measurement of behavior, and then we'll talk about implications of this debate. And when you think about a disease model, you can think about, this sort of core basic model that we all think about, that there's an etiology, there's a pathophysiology, and then you have symptoms. And we define disorders in each of these three different boxes. So for example, something like COVID, when we think about COVID, if you are exposed to, say, the virus, you have COVID. You may develop respiratory tract damage, you may develop symptoms of COVID, but even if you don't develop that damage, and even if you don't develop symptoms, we say you have COVID if we detect the virus. So it can be located from a very clear understanding of the etiology of the condition. Then there are other conditions like Alzheimer's, which definitionally are located in the pathophysiology. Certain elements there definitionally lead to a diagnosis of Alzheimer's. And you can think about a third kind of condition, something like conversion disorder, where there's clear symptoms, really remarkable symptoms, if you've ever met someone with conversion disorder, and yet there's no clear neural deficits related to that symptom that they're having. So in all three of the boxes, you can locate disease and definition. What about psychopathology? What about mental disorders? Well, we're left with these kind of two boxes that we think about, the brain and behavior as where they are. And pretty clearly the zeitgeist for the last few decades now has been that psychopathology is a brain disorder. This is Thomas Insel, who led the National Institute of Mental Health for many years, and Bruce Cuthbert developed RDoC, which many of you are familiar with if you work in the area of psychopathology. This is sort of their manifesto where they really lay out the idea that in order to make advances in understanding psychopathology, we have to study the brain. And in fact, from a funding perspective, it was going to be easier to get more NIH funding if you suggest the biological substrate is where we're going to make progress in thinking about psychopathology. American Psychiatric Association couldn't be happier. Every branch of medicine has its favorite organ that they study. Psychopathology, of course, is going to be located in the brain. That's where we're going to make progress. Even patient advocacy groups like NAMI, for example, suggest mental illness are biologically based brain disorders, and they're not related to character intelligence. And for them, it was, let's get stigma off of mental illness. Let's treat it like a disease, like a brain disorder. And so if you think about this kind of paradigm, and again, we're not being simplistic. It's not an either or. The question that we're debating is not one of ontology of what is a disorder. It's a question of effect sizes. What are the effect sizes that we can realistically expect if we pursue a brain disorder-based view of psychopathology versus if we pursue a behavior-based pathology? Where's the limits of the effect sizes? So if you came for philosophy, you're going to be disappointed. We're going to talk about effect sizes today. So brain dysfunction in the brain paradigm, the dysfunction is definitionally in the brain. So abnormal behavior is just, its visible manifestation. And people talk about, depression is a chemical imbalance, alcoholism is a disease. This is all carrying that sort of brain idea. And the key thing to remember in this debate is that we're not talking about, everyone can come up with exceptions in psychopathology, things that are clearly related to brain dysfunction. We're talking about the preponderance of psychopathology, about Kreplin saying, hey, you forgot to come back to what most people suffer from. If you take this view, then one of the corollaries is that brain disorders don't necessarily cause abnormal behavior, that you can have dysfunction. It's definitionally a problem in the brain, some circuitry, some area, but it doesn't necessarily mean you're going to have symptoms. So, for example, silent stroke. You can have a silent stroke without any visible manifestation. Some of the core assumptions in this kind of paradigm view is that we're going to be able to find reliable matches between brain anomalies and psychological dysfunction. And it's a problem if different people have different circuitry leading to the same symptom, like worthlessness. This definitional paradigm is that really we are going to be reliably able to detect certain circuits and certain regions that reliably predict psychopathology across people. And if we don't, that's a bit of a problem. The second kind of assumption is that dysfunction at the mental level indicates dysfunction in the brain. In other words, can you have a healthy brain realizing unhealthy behavior, like pathological behavior? Is that possible? And you can imagine a case like, say, for example, a phobia, where a healthy brain will run from a severe danger, but you can imagine learning to apply that somewhere else and it being dysfunction. So there's some testable predictions in this paradigm, and this is just to keep it at a broad level. One is that specific brain pathology is going to underpin most disorders. And sure, we might have different pathologies, but they're going to be limited in number. The second is that we're going to be able to develop diagnostic biomarkers. So again, we're thinking about which paradigm is going to lead us to the most prediction of psychopathology. Are these diagnostic biomarkers going to do it? And the third is the most effective treatments are going to be brain-based. So medications that work on neurotransmitters, neurostimulation, neurosurgery, for example, for OCD. In contrast, you can think about a different paradigm that thinks about psychopathology not as fundamentally brain-based. Of course, it's brain-based, but not that the real bang for your buck is not going to be in the brain, but really at the behavioral level. So that behavior is definitional. So that it's more than, and when I talk about behaviors, it's more than just symptoms. We're talking about behavioral mechanisms. So for example, attending to my body, like in anxiety sensitivity, leading to panic symptoms and panic attacks. So hyper awareness of what's happening in my body, very behavioral mechanism of attending to my body, leading to panic attacks. And key in this is this idea that if you clinical significance, in other words, if you have distress or impairment, that's a behavior, and it's definitionally necessary part of this kind of behavioral paradigm. Okay, so there are some predictions that you would expect with this paradigm that, first of all, we're never going to find major brain pathology when it comes to psychopathology. That hunt will have a certain limit and it won't go beyond that limit. There are going to maybe be lots of small effects because all behavior is related to the brain, but they're going to be small effects. And that objective behavioral markers are going to have much higher accuracy when we're predicting symptoms than biologically based markers. And then third, that behavior-focused treatments can be curative, psychotherapy, public health programs. So these are the two paradigms. It's not an either or, that's a provocative title, but it's a really question of where are the limits of each and what can each do. So Roman graciously volunteered to come and talk to a bunch of neuroscientists about why With the limits of some of the evidence might be.
Yeah, that's now my part. Then back to Camilo. I will talk about etiology box first, real quick. So what we know about etiology of mental disorders is most clearly learned from twin studies. And twin studies indicated on average it's 50-50. Between 40 to 70% of vulnerability to mental disorders come from genetics, and the rest comes from the environment. So right away, we're running into some complexity. But what about the genetic piece? Well, there are multiple ways to unpack it. We will do this now, but starting with common variants. This is polymorphisms that are relatively common in the general population, and we refer to them periodically as SNPs. And what I'm showing in this table is from genome-wide association studies, the single most predictive SNP for a given disorder. These are odds ratios. The largest one in this table is for schizophrenia. So what this odds ratio tells us is that for our best case scenario, if baseline prevalence of schizophrenia in general population is 1%, then the carrier of this SNP has 1.23% risk of schizophrenia. So a very small increase, and all other SNPs contributing considerably less than what's in this table. Now, there are some vulnerabilities that are much more powerful. They are much more predictive. They are perhaps causal, but they're just much rarer. I'm focusing here on schizophrenia because this is the most genetic condition that we have. It is best studied in genetic studies. And so for them, there's 18 rare variants have been found. What you have on x-axis is prevalence of polymorphism in the general population. And on y-axis, you have odds ratio of having schizophrenia if you have a risk allele of this polymorphism. So in blue, we have this SNPs. We have hundreds that have been linked to schizophrenia, but they're all tiny, tiny odds ratios. Then much less frequent on the left, but odds ratios for this rare variant start at 3, go to 100-fold increased risk. So that may be strong enough to be causal, but it's so rare. And this study has included over 22,000 patients with schizophrenia. And these are the numbers of cases that carried each of those rare variants. So altogether, even if they're causal, they have explained less than less than half of 1% of cases. And there will be future discoveries. We'll find more rare variants. They will be just progressively more rare, because if they were common enough, we would have seen them in this study and many studies to follow. So this is basically a snapshot of what's happening with schizophrenia. It's even worse for other disorders. That tiny piece rare variants, and we had to have 18 different genetic conditions basically to even capture that little piece. If the red piece will grow, so will complexity. But the blue is roughly a quarter, this common variant. And again, we have numerous numbers of SNPs, each contributing a tiny fraction. Environment is what we know. We don't know what in the environment causes schizophrenia, but we know that it accounts for that much. And then gray is the unknown part, but it's also a mix of course, genetics and environment. All right, so what do we do then? So a quick, super primer kind of review of polygenic risk scoring. So when we have large numbers of risk factors of small effect, then we can, in discovery sample, find risk associated with each allele, and then we take one individual and we count the number of alleles that they have at each location, multiply it by risk associated with each allele, sum it up, give us a total score, total risk for a given person. This is polygenic risk score. This, as you can see in this table, is an actual table from the latest GWAS of schizophrenia. So they use 7.5 million SNPs that they analyzed in their genome-wide association study. Do you need that many? Well, here's an illustration from depression. I picked one, but typically this analysis follows this pattern. So for depression, you only take SNPs that are genome-wide significant they explain almost no variance in risk for depression. I mean, that's about 100. If you put in 10,000 top SNPs, then you'll be able to explain it's what small fraction. It's not that it's not imperceptible anymore, but it's still very small. You increase it to 1 million, you'll explain more. You put all of your SNPs that you're able to genotype, you maximize your prediction there. So in other words, to get good prediction, we have to embrace complexity. Let me just say this. How would a polygenic increase scores today? And they will get stronger as we go from sample sizes of hundreds of thousands to hundreds of millions. So, but that's what it will take to get them a lot stronger. Where we are now, this is one study that we've done. It's just an illustration. Polygenic, we obtained all these polygenic risk scores that you have as rows. And as columns, you have different psychopathology scales that we scored from child behavior checklist. This is a BCD study that I suspect that needs no introduction, at least for this group. And these are correlations between each polygenic risk score and each psychopathology scale. And the significant ones are highlighted. There are many significant, and many of them are significant, and they follow sensible pattern. But the highest one is correlation of 0.101. And yes, under some conditions, you can probably double it for some special populations, some special outcomes. But that's roughly what we're dealing with. Even once we combine together this numerous effect, the numerous SNPs, let's say, we only get small predictive effect. Not enough to define psychopathology with. Environment, like towards an environment, is no easier. It is also multi-layered and complex to the point that we don't even have good nosology or typology of environmental inputs. But let's think of the easiest case you have. PTSD, post-traumatic stress disorder. We supposedly know the cause, like totally complete understanding we would hope for, because trauma is what caused PTSD. You know, trauma exposure, and you know PTSD, and turns out it's not so simple at all. This is the data from 10,000 plus responders to World Trade Center disaster. They participated in this monitoring program where the PTSD symptoms were repeatedly assessed up to 16 times using PTSD checklist, a standard clinical tool. And so now we aggregated all this data, creating the most robust, precise phenotype we could, related it back to assessment of exposures that they suffered on 9/11. We accessed 11 different variables, 11 ways in which person could have been exposed. That explained less than 4% of the symptom burden across the 10,000 responders. Now, symptoms also, they're not set in stone. They also respond to life events and stressors. Okay, so we added 18 life events that were more proximal. They added another 15%. Never mind that these are life events and not traumas. And they do account for more variants than traumas. But just let's reflect on the fact that we took 29 different factors, and together they explained about 19% of variability in PTSD symptoms across people. And we're expecting, based on twin studies, at least 50%. So in order to capture all of the risk from the environment, you'd have to have hundreds, at least 100 of different factors that we consider. Also really tough to derive definition based on that. All right, so now switching to a selective review of neural evidence, meant to be provocative and to generate discussion. So starting off just that testable prediction that Camilo highlighted. And one way to look at this is meta-analysis. Easy one is neurosynth. This is because it's online. You can go in the tool and put in your keyword, see where studies have consistently found associations consistently. And so if we put Alzheimer's and we meta-analyze in real time, fMRI studies of Alzheimer's disease, we see a significant area in entorhinal cortex. It's been replicated across all studies. We take schizophrenia, we see nothing. It's not because there are no findings, lots. but they're all in different locations. They're all over the brain. They're even in cerebellum. We do the same for major depressive disorder. No consistency again. Now, meta-analysis are limited by the data going in. So there are file door effects and other biases that you can't really control after the fact. But Enigma, you guys know this consortium and they work very well as well, has been accumulating raw data and then doing mega-analysis. So taking unbiased approach with large samples, for example, to look at major depressive disorder, relating that to alterations in cortical thickness. And in this large study, the largest effect of all the regions in the cortex that they've considered was so tiny as to explain less than 0.5% of differences in major depressive disorder cases and non-cases. Then the same, just a little bigger, for white matter, and this is all Enigma studies to show, white matter alterations. But white matter alterations in PTSD show exceedingly small associations. And again, I'm focusing on the most informative region. All the rest of the regions are even weaker. Cortical vacuum in PTSD. Now, white matter abnormalities in schizophrenia, it's a matter. A single region can account for as much as 4% of variance and rates. The biggest one of all Enigma papers that I read so far in any case is cortical thickness in relation to schizophrenia and cortical thickness. In top region, 7% of variance, effect size of 0.53 standard deviations. Can we run this that? Well, this is what it looks like under optimal conditions. If you have 50% of your sample are cases, 50% are controls, the two distributions on this one biomarker, the top region, would be highly overlapping. But if you go to very extreme levels, like Z-score at the bottom, then you would see some regions where it's pretty likely that you're a case, in another region where it's pretty likely that you're control. So maybe you could use that. And however, in the general population, schizophrenia has prevalence of 1%, and we get this. And so healthy people are so much more prevalent, they completely swamp the schizophrenia distribution. So it's no matter how extreme the biomarker, the answer still is this person got to be healthy just because the base rates of schizophrenia are so low. But I was just talking about individual regions, picking one at a time. Obviously, numerous regions are involved, and can we, as we molecular genetics has done, pull all these small effect sizes into something polygenic risk score for the brain? Let me provide one word of caution. There is a lot of literature showing that some are positive, some is not. But the infamous Merck et al. 2022, not to take sides, but unpack what they actually found. So they took ABCD data, 4,000 participants, split this into two halves, holding out one half for replication, train machine learning in the other half, progressively sampling, increasing subsamples from it. That kind of very short to my point, but that's what they did. They had two imaging modalities, resting state and cortical thickness. They used two different machine learning architectures. The target that they were predicting is back to CBCL, child behavior checklist, total score. Okay, these are the results. And on X and Y axis, you have how well model one strain performed in sample. So in the same sample was trained in, these are correlations on the y-axis. Let's not even worry about that right now. A lot of heat goes around y-axis. I'd like to focus on X. X is how well the resulting model performed out of sample in replication. And much smaller, but more importantly, the best performing model for resting state and support vector regression gave us correlation of 0.16 out of sample. It's not significant. When gray bar is where region of significance begin. Yes, it is significant. It's just not very informative. If we go to canonical correlation analysis, we get a correlation of 0.19. If you go from cortical thickness, we get effects that are a bit smaller. 0.11, 0.14 correlation all the time. So why can Can we do better? We certainly can with larger samples, with more thoughtful modeling of the brain, but this is what we're starting with. After a lot of work, that's what we got. In contrast, if you turn to dimensions of behavior, such as neuropsychological test scores, we have no trouble finding very large effect sizes. This is a study that I lead at this point, so I can tell you guys every mythological detail if you're skeptical, but focusing on that, we had 600 patients with psychiatric disorders, first admission. They completed the neuropsychological testing. We compared them to norms on this neuropsychological tests, that is to healthy performance. Some deficits as large as 2.5 standard deviation. Very consistent with the literature. When you give people a quick neuropsychological test, you can have a pretty reasonable prediction whether they have schizophrenia or not. And we have these instruments available for decades, and they have objective measures too. Complementing this with personality assessment. Personality trait analysis we've done some years ago. On the left, you see comparisons between disorders and healthy control groups on neuroticism. On the right, you have other traits in a summary fashion. So neuroticism is the biggest. Other traits also show pretty major deviations from health. So we get effect sizes as high as 2.25 standard deviations. Like people with PTSD, 2.25 standard deviation higher than people without on neuroticism. Okay, so why is this so easy and so large in comparison to what we get out of the brain? I mean, this is $1 billion question that I don't pretend to know the exact answer, but I have a hypothesis. So let's reflect on the following issues. So if you're trying to understand schizophrenia, one disorder, and you're trying to understand it from behavioral perspective, things like cognitive functioning, personality functioning, we probably only need 200 to consider 200 dimensions. At least this is our best estimate of the dimensionality of complexity of abnormal behavior. We cannot break it up we can't make it any more granular. We wish. Okay, so we are dealing with 200. When we go to the brain, let's say we are just doing functional connectivity, and only in the cortex. And obviously, there are other many important imaging modalities, but just sticking to this one, that's already 64,000 connections. Of course, majority of them will have nothing to do with schizophrenia, but suppose just 1% does. That's 640 individual connections that are contributing to schizophrenia. Can any one of them be of a large effect size? Extremely unlikely, because we're dividing the spy in 640 ways. The most likely scenario is that all of them are contributing something rather small. When we go to molecules, we are on the order of hundreds of thousands. When we go to SNPs, we are on the order of 100 million of variables. That is biomarkers that vary between people, and some of them will be relevant for schizophrenia. So in fact, we're progressively getting greater complexity, more parameters, smaller effects. Okay, to put it differently, and I'll conclude my part here. So if you have, we know that psychiatric disorders are, on average, as a group, associated with hyperactivity in dorsal striatum. If we redefine our topic, our condition of interest as dorsal striatum hyperactivity disorder, we're good. We have the region, we have the way to image it, we have therapies that can be specific, or at least made specific, to reduce this hyperactivity, the neurostimulation or drugs. But that region makes only small contribution to psychosis. Psychiatric disorder has very complex neural architecture, so many of these roads are blocked to us for that reason. Not to say that complexity is always there. We have a number of conditions that used to be psychiatric disorders that have very clear either etiology, like congenital paralysis of the insane due to syphilis, or pathophysiology. You can diagnose epilepsy, and we only diagnose epilepsy with EEG. And we give, as Camilo made the point, we gave them away. Like once we knew etiology, pathophysiology, they went to other areas of medicine. So by design, we are left with multi-determined in psychiatry, multi-determined complex conditions. Camilo, you're next.
This is great. Trying to give a joint talk. So thanks, Roman. That's fascinating, review the evidence. And so I'm supposed to cover evidence for measurement of behavior, but that is too ambitious at this point. So I'm just going to illustrate just a few points of why we care about this and why we're having this debate right now, while Roman and I have been talking about this for years now, and why so many people, I think, are. And part of this is because for many decades, psychology, unfortunately, this is a kind of a joke from Baumeister. Psychology is the science of self-reports and figure movements. We were limited in psychology by methods. We weren't actually measuring behavior. We were measuring, using self-report savers and stuff. In the last decade, that, as all of you are incredibly aware, if any of us, is that that's all changed due to just technology, the availability of AI-based behavioral signatures. So now we can develop behavioral signatures. And one of the contentions we have is that shifting back to this idea of focusing on behavior can actually create a science that is impactful. So what does that look like? Well, we're doing this already, and Roman and I have been doing several studies over the last many years, playing with these kinds of models. And you can take off the shelf something like Face Reader that automatically codes facial features and does it quickly, head movement, all sorts of behavioral features. And I think I'm accidentally moving this. And when we do this in something like schizophrenia, for example, we're finding effect sizes that are not overwhelming, but we're getting correlations up to 0.30 based on just a passive recording while a person's talking about their symptoms, things like head movements, certain emotions that you can code with something like Face Reader off the shelf. So the behavior itself, we're able to get some pretty decent leverage in terms of predicting. We can even use it as a screener for prediction of, say, schizophrenia versus no psychotic disorder. This is a paper we did with Liz Martin from UC Irvine, where we use this to predict whether a person had schizophrenia or not, and decent odds ratios, again, area under the curve of 0.79. This is pretty good work for something that doesn't involve any reference to the criteria at all, but really just a coding of a person's facial features. I've been working with Roman and Ben Luft on the World Trade Center cohort for many years now, more than a decade. And that sample, we at one point asked them to record diaries of their day, how their day was. And then we used those diaries of how they were talking about their day, and we were able to use natural language models to code personality features about them, not based on any kind of report of their personality, but based on their language they're using. And something as simple as that led to, again, not overwhelming predictions, but correlations as high as 0.37 for depression, for depressivity. So when we code their personality based on their language and try to then predict psychopathology. So again, the point is that the hope here, and this isn't an exhaustive review of evidence, but the hope is that these behavioral paradigms will lead to more progress in treating psychopathology and predicting. Even if you take meaning out of behavior and we just focus on a real low-level behavior, one's acoustic speech, in other words, the pitch at which you speak, the speed at which you speak. In other words, we're no longer using AI to code what you're saying and the meaning of what you're saying. We're using it to code just absolute features, over, I think, 1,000 different features that you can extract, very subtle ones, very hard to explain, the area models, but even that we can get prediction of MoCA scores, for example, a 0.28. Again, this isn't going to be super clinically tractable, but that's pretty good for something that's based just on how you sound, really, and AI is picky. The reason we're super excited about it is we now have applied this to the World Trade Center clinic. Every time someone calls the clinic, they understand that they're being recorded, but when they call to work to make an appointment or to talk about their medication management, all sorts of prosaic reasons they call the clinic, brief calls and long calls, we're recording them. And based on those calls about their scheduling, for example, we can use that to make predictions about clinical variables we care about. For example, PCLs, their PTSD severity, MoCA, you guys are probably familiar with MoCA. So again, small effects, very small effects, but this is off something that happens every day, all the time in clinics all over the country and world. So again, the idea is that this behavioral paradigm can really start to get legs in terms of making a dent in psychopathology. It's pretty clear where this is going. This is an example. This box here is a DAC, I think it's called.
DAX.
DAX, right. The dragon, I forget what it stands for. But anyway, DAX. These are in 200 different clinics in the country. And this is basically what it does is a clinician walks into the room and it immediately starts recording their voice and the patient and the conversation. And it creates a clinical summary and note for the clinician based on that conversation. It identifies the clinician, identifies the patient, and generates a note so the clinician doesn't have to generate a summary note. It does it really quickly. It's kind of like the Zoom meetings when it creates a transcript for you and a summary of that meeting, same kind of thing. You can imagine applying the AI models that we're training right now into this so that you now suddenly have a screening instrument. So someone comes in, they're talking to their doctor about, an accident, car accident, the sequelae of that. You can also screen for PTSD at the same time, silently in the background with these models. So incredibly powerful where this behavioral paradigm might take us. And so this is kind of where we're excited about this. You can imagine digital clinics. We've been talking with John Torres at Harvard. He's got a colleague here at UT Southwestern, where we're beginning to use ecological momentary interventions. The data we're learning from EMA to apply behavior paradigms in the moment when a person, for example, is beginning to catastrophize, things like that. We can apply these behavioral interventions in the moment. And you can imagine a digital clinic where it's not just therapy, it's not just, and contrast this with what you might think about when you're working under a brain paradigm, where you're going to image someone and try to get some clinical utility out of it. The clinical utility here is enormous. And even, I'll go a little faster, I'm not sure. Even something as biological as schizophrenia that Roman was talking about earlier, we know that behavioral interventions work really well. These are from meta-analyses. These are antipsychotics in the forest plot. And then you have meta-analysis results when you add psychotherapy as an adjunct. Psychotherapy, even for a biological psychopathology like schizophrenia, the most biological one we have, psychotherapeutic behavioral interventions have tremendous effects. Those are really good effect sizes. You can imagine applying behavioral paradigms in the moment through this kind of digital clinic. And in fact, there are lots of RO1s out there trying to do this with schizophrenia. That was positive symptoms. Even for negative symptoms, you find effect sizes from this behavioral paradigm that rival anything, in addition to antipsychotics. So you can imagine this paradigm and investment in it really leading to bigger bang for your buck when it comes to this challenge of trying to treat psychopathology. Okay, Roman, would you like to talk about some implications?
Yeah, so
Right.
to wrap up, and we can just get to the end of implications, but I also really encourage you to jump in as interesting points come up. We can debate them. So to start with a quote, Tom Insel was saying in 2015, brain disorder paradigm. 3 years later, he was already saying, I came in, this when NIMH as a director, with the bias that we could fix the diagnostic problem with genomics and imaging. I was wrong. We spent a lot of money on both of these efforts, and at the end of the day, we found only a little evidence. It was not the transformative technology that we had hoped for. That is when I began to realize that we first need to get the phenotype right. Perhaps we're not even ready to know what genotype to look for because we don't yet have the behavior or cognition right. Now, at this point, he's no longer an MH director. He is working for big tech. So take this with a grain of salt. He switched allegiances. Interesting which direction he switched to. And okay, that being an anecdote, let's talk about what we can infer about etiology, at least what I could infer. Well, it seems that the majority of people, not counting some exceptions, with these mental disorders, etiology and pathophysiology is highly complex. That is on the biological side for sure. Now, we have psychological mechanisms that I mentioned some examples of that are much more proximal, and for that reason, likely more powerful. What I'm talking about is triggers of particular symptoms such as drug use, triggering craving, or trauma reminders, some associated, person associated with trauma they've experienced in the past, triggering symptoms in the present, various reinforcers of maladaptive behaviors as they occur in real life. Cognitive control, different capacity for cognitive control, individual differences in coping strategies. And we can intervene with these mechanisms directly and deliver treatment in this real-time fashion, but also tailored to a particular mechanism that this person is responsible for the symptoms. We have underutilized them. That's a fact, but it likely is because, at least my hypothesis is that it is because of a measurement problem that Camilo described. And yes, South reports are just really not counting it in terms of the ability to capture these mechanisms accurately. But now we can, especially with natural language processing, but other tools can get us objective pH of mechanism. So on the biomarker side, again, let me underscore, not be shy to jump in. We have, by and large, in psychiatry, certainly my department, have been pursuing theory-driven circuits and explanations for psychopathology. So we are looking at the many lampposts, while vast regions have been left basically neglected. And we found only small effect sizes, at least when we try to replicate in large samples by independent groups, effects that seemed large turn out to be tiny. And we may be better served by setting our theories aside, at least for some studies, and doing hypothesis-free but comprehensive and large sample analysis. And that's, of course, what genetics was forced to do. And they discovered that their computation, none of them were right, or almost none of them were right. They had many other discoveries, however. Now, we still should expect small effect sizes, but many of them. So if you do brain-wide analysis, the next step may be supervised machine learning, where we aggregate all these individual facts into scores, sort of like polygenic risk score for the brain, that much more powerful, but of course a pattern, because so many inputs go into this black box. So if you're interested in a given hypothesis, or testing one hypothesis, nothing wrong with this. But if you're applying this to understand mental illness, not not a neural process, not a basic process, but make this translation from the brain to psychopathology, expect effect size less than 1%. That is 1% of variance in psychopathology that a given process will be able to explain. If you get bigger bang, great. But if 1% is what it is, then you need 780 participants for 80% power, just to put like some sense of scale on the studies needed. And if you do 400, if you can only afford 400 participants, well, that's probably a coin toss whether you're going to find the effect that you're looking for. Machine learning, of course, can help by increasing effect sizes, but while you're training these models, you need to correct for FDR, you need to have a holdout sample, your replication sample. You probably need more power than conventional statistics. It's down the line, once AI is trained, that you will benefit from larger effect and can lower the sample size. Behavior is also complex, because when you say, oh, this is like really interesting, highly predictive markers, they're composed, let's say, in case of natural language processing, of thousands of individual words and phrases, also combined with differential weights. So to get reliable, strong behavioral signatures, we also need banks, just behavioral banks. And this can be accomplished with collecting audio, video, smartphone data, perhaps in the context of telehealth, marrying it with electronic health records, such as diagnosis that are available for patients in a given healthcare system will consent for such an aggregation. You can get there to tens of thousands, perhaps hundreds of thousands of participants. That could be the data that is accurate behavioral signatures. Of course, even if they're accurate, we can assume that they will be helpful. That is always a test. Clinical utility is a separate test for any marker. Okay, a couple words on treatment, and we're basically at the end. Diagnosis, and we didn't really talk about this, just take it as my perspective, that categorical diagnosis, the initial diagnosis, cannot serve us well in terms of treatment selection or prognostication for a patient. It is likely that both biological and behavioral signatures of psychopathology will provide better guide to treatment. So working in that direction, I believe, is very practical. And we can, as Camilo described, plug AI into telehealth visits or in in-person visits, especially if DAX or similar technology is already in the exam room. And that would improve psychological measurement, including during intake, but also during monitoring of treatment response. As Camilo was saying, digital treatment can be more powerful than standard psychotherapy. Why? Well, it's a matter of dose. So you do not have to limit intervention to 1 hour a week. It can be every day. It can be multiple times a day. It can be in circumstances where people actually need to practice the skill. AI detects the abnormal behavior, whatever is the target. Let's say they went into a bar, in case of alcohol use disorder, and intervention is deployed, of course, with patient consent right then at that time. Well, that is still future promises not yet fulfilled, maybe will never be fulfilled. But one thing that is clear is that in the United States and across the world, we really have far greater mental health needs than providers. We cannot train our way out of this problem. We cannot afford that many providers that we need. But with digital therapies, they can be very scalable, or they can leverage one provider 10, 100, maybe even 1,000-fold, resolving issues with access both in terms of scale and also access in underserved communities. So to conclude, the paradigm that I find helpful in thinking about this is really not mental health at all, but traffic accident prevention. So these are problems that lead to death. Humans do it, and nearly all of these deaths are preventable. And they have complex causes. In some cases, excess speed. Sometimes it's impulsivity or distraction or intoxication, impaired vision. And we have not taken a medical approach to this. We've taken a comprehensive approach. We are using biomarkers such as blood alcohol concentration tests and eye exams during licensing and DMD. And we also use behavioral tools where appropriate, such as red light cameras and police radars. And our interventions include various incentives, laws, insurance company rules. We design roadways with accident prevention in mind. We design vehicles for this, and we have many other behavioral interventions, such as the driving test that require people to pass. All of this is behavioral, by the way. We're acting, even though the problem is in the brain, ultimately, we're acting on it for behavior because that's what is tractable. So my message is really this paradigm is twofold, well, threefold. One, looking at this in public health perspective, not in patients showing up at the clinic, but on the scale of prevention. Two, both biological and behavioral modalities complementing each other. Three is that we are unlikely, if this is a good model, then we're unlikely to get out of burden mental illness with progressively developing more and more sophisticated drugs. But you need to take a comprehensive approach. So we're ready for questions for sure. Jennifer, please.
I feel like I should have asked this not in this room, but this is the first time I've heard people talk together. So I'm struck that at the end you said all the things I wanted to hear about the larger complexity of the system, environmental and health. Whole talk. And so I found that interesting. So at the end, when you're talking about maybe we're going to get rid of all the psychotherapists and there aren't enough anyway, your evidence for that is fairly low effect size, like rate, of people who are calling into a clinical setting as established patients who've already presented. So why is that effect size one? Because basically you're just picking up on general psychopathology. And I would argue that if you put an exceptionist next to them, there's a good chance they could do a better job of thinking because of stress. But what I do see is really helpful is this idea of if the cost of the to surveil a population, then really could start identifying where are you starting to see an outbreak of distress, and you can mobilize your resources to that immediate area so that you can focus on prevention, as opposed to thinking you're going to really offset somebody who's in an acute psychotic crisis by having a bot paradigm.
So lots of threads. I will not do it all justice, but what stands out to me as the biggest thread is, yeah, where is the public health data in the store? It's not there. It's not there, and for I think a really good reason that none of these technologies I'm aware of have been deployed at this point at population scale. And this is more, previous slide was more call to arms kind of message. And it is the many hypotheses we can offer why it's not deployed at this level, unlike what let's say we're doing with fluoride in the water. It might be a wonderful example of masks, the mask mandate and such. I think fundamentally we have not proven that these tools would work in a given community. So this implementation piece, I think, not yet done, can be done. I hope in a matter of just a few years. Once it's done, I think we can take it to the policymakers, not me personally, to policymakers to scale it up to state of Texas or to the United States. What do you think?
Yeah, I still agree. The larger point, and I want to emphasize this in this talk, is that this shift in paradigm is happening. Google is driving it. Other people are driving it. It is a shift that's happening, and I feel like we're on the precipice of a change in psychopathology and how we treat it, and the progress we can make. And part of it is because of the shift in paradigm from brain to this behavior focus.
One thing just to say, triggered by your thing about fluoride, I think there's some evidence that lithium concentration in the diet of different communities actually can be associated with differential diagnosis of affective disorder in the same region. Speaking about public health measures for psychopathology, perhaps we should all be lithium dosed like that. But the point I think it's a great talk, but just in terms of separating out issues, seems to me that one thing that's super important is to distinguish between three goals. One goal is the mechanistic causal understanding of behavioral disorders. That's going to not necessarily be the same kind of research program that's going to give rise to implementable treatments that can be implemented on a very large scale, digital thing. But it's not clear to me that the development of treatment at that level necessarily is going to tell us anything interesting from a scientific point of view about the mechanisms underlying the disorders. It's easy to think about the history of clinical psychology, is the history of developing treatments based on now discredited theories, which turn out to work, but not for the reasons anyone thought when they were developing the treatment. And then thirdly is this issue of biomarkers, which don't necessarily tell us anything about the underlying cause of the disorder. So your example of speech stuff, that could be a very, I think the effect size was quite small, but even if it was big, it would tell you something about people that are perhaps at risk of having a disorder. Perhaps, think of it as just being a hidden symptom, something that you don't appreciate until you do the analysis, but it's just another symptom. But no one thinks, I think it's unlikely that modifying someone's speech style to modify their behavior is simply a correlate. So I think those three levels, what's needed for effective intervention, what's needed for a causal mechanistic understanding of the disorder, what's needed for variables that are predictive of people who need help. Obviously, they're interrelated. They're very separate. I thought in the presentation they got kind of mixed up. Rob, I think it's probably helpful to keep it separate.
It's great feedback.
Very, very true. It is also true that I think we are making, of course, headway in theological understanding of theological understanding with the neuroscience, where we try to translate it to biomarkers. So we struggle. That's the market by this stuff problem. Not that it's many risks for back sometimes. Businesses biomarker. I like them. I use them in a research context. I just won't see them as particularly helpful for diagnosis of infection. But in the drugs that we have, and they are effective, we still don't understand really why antipsychotics are effective. Yeah, they are. So that's a well-known, I think, of kind of summary of what's happening on biological side. On behavioral side, it's much more uncharted, right? So we did not get these tools like in a way where we can get sufficient sample sizes to thoroughly answer these questions until like a few years ago. And what Camilo showed with coding of facial expressions, that would take somebody an hour to escape. And so you can either do very quick recordings or you can do maybe longer recordings, but over a dozen participants. What can you do from such limited data? Face Reader produces within an hour a billion frames or so of data. We are swimming in it, having trouble with the bioinformatics side. So, but what I can say is that there are methods for deploying this for understanding mechanism, and including on the linguistic side, that's what I'm most excited about, measuring potential mechanisms like catastrophizing, for example, objectively. The biomarkers, you see, behavioral. Like, you see some promise, now if you consider correlation 0.4 promising enough, but this is a start. And this is still samples of a couple of thousand or such. We really need 100,000 to know how far this can go. And on the point of treatment, I think Jennifer's point is very right that we have not proven deployment on population level. But of course, many efforts are happening at the level of sample patient there. What they will adapt to, we don't know yet.
One of the challenges of the point you brought up, though, is that the pursuit of mechanisms is tricky in the AI world, where you're extracting features that you really don't understand how they operate at all. And so you can think of them as just simply corollaries, or you can search for some mechanistic science.
It seems to me that AI is not going to be helpful. AI is great for prediction and aggregation. It's not going to give deep insights, I don't think, into the at the level of tech.
So what we can do on the psychological side is that we can train a model to discriminate, let's say, between speech that is logical and bias, so kind of distortion data. We can identify locations where the person like trigger, or whether it's creating or maybe phishing or something else. In multi individual, we will really differ patient by patient. So it's not a simple task, but AI can help us with that. So there are some ways in which we can take this AI and make it more explainable, make the black box a bit wider. But it is not an easy process at all. It's not guaranteed that you get great investigate by.
Yeah, so everything you presented, it's kind of looking at these things all in isolation, but what happens if you try and put things together? Like, can you get better predictions if you're combining behavioral mechanisms with other behavioral mechanisms, or adding the brain in to that?
I don't know.
I think it's basically non-existent. This literature that would take both biological markers and hero markers. That's
Because
the point, right?
there's Emily Falk has some work where she showed that, like, just with self-reports, you can predict behavior in the real world, but if you add neural mechanisms on top of that, you can get better predictions.
Right.
Neural mechanisms are providing extra information. This seems like another area that would be right for combining information, especially if you're already using AI.
Absolutely.
Yeah, no, it seems really promising. For me, the most fascinating thing about this talk is the replication crisis that we're in. And I think the behavior side is going to face this replication crisis as it develops. I mean, we're already kind of there. I think the complexity is increasing when you're adding all these factors that you don't necessarily understand clearly how they will all bring together.
Well, to give a little.
And I will say it's 1:00. I know people have to go. So yeah, Roman, do you want to?
Yeah, no, for myself, I'm happy to keep talking another half an hour. I kind of want to come up and chat just small bit easy. Don't hesitate. But to answer this speech about layering behavior in biology, get published papers, I'm not aware of anything. But I'm aware of growing data. For example, UK Biobank, yeah, they have molecular data and they have a lot of imaging data. And they send actigraphs to 100,000 members of the biobank, and they collected like 2 weeks of activity from each of them. Unfortunately, these were very basic devices, so we cannot, for various privacy regulations, we cannot do precise geolocation from this data and say like, oh, this person was going to a bar and this one wasn't. But we can, they simply work doing genome-wide association studies of activity measured from these devices objectively, and being able to take some activity-based markers and add them to existing, let's say, PGA increase scores or neuroimaging markers to predict clinical outcomes. It's there, it's doable, and I think within a few years, many repositories like this.
Let me ask to the remote audience. Camila, is there any question online?
I do. I have 2 questions. The first question reads, can you expand a little more on the digital clinic and how psychological treatments can work digitally on a large scale?
Sure. John Torres has written probably the most on this, and really, digital clinics are adjuncts to therapy. So, for example, your therapist tells you to do something or compliance with medication, and you carry an app with you that delivers an intervention. For example, there's lots of CBT that's been put on apps, things like that. So these digital clinics are virtual, in the sense that really you're paired with what's called like a digital navigator that helps you select which kind of digital app will help you the most and when to use it and how to use it. We've been playing around a lot with ecological momentary interventions. In other words, interventions that aren't applied until you really need it in the environment. And so that's the idea behind digital clinic, is that it's something you can scale up pretty quickly. And we're playing around with this idea of having app-based treatments. I'm not a fan of apps, but this is the idea behind these digital clinics. Also, inserting AI into the clinic room in many more ways, like we talked about with the DAX. That's what it's called.
Well,
You want to expand?
I want to take opportunity to come back to a point that Jennifer brought up. We're not cutting, at least I don't think it's a wise idea to cut humans out of this loop. Certainly, bots can go awry, and they periodically would, and causing harm. But also for credibility and for some level of connection with a human, this is so important, because ultimately, who wants to be talking to a bot, right? But if it is in the context of a bigger conversation, it's a human provider, I think it's a bit more palatable, more attractive, and I must see this as leveraging one person to do a job of 10, as we need to do to reach everyone who has mental health needs, as opposed to replacing human providers.
And just to follow up on that, Jennifer is doing really fascinating work of looking at the provider shortage in the country, and we'll never train enough people to provide services. And so these digital clinics are really going to hopefully fill that gap between access and need.
What's the second question?
The second question says, could certain behavior and verbal signals be a false positive based on the neurotype of a person? Also, sorry. Oh, it's a long one. Also, given these overall results, how much of a psychopathology would you think is explained by typical biological features? And how much is explained by a person's environment and prior experiences in life? I'll stop there and then I can read the third part of the question if you'd like. Or do you want me to continue? Oh, we can't hear you right now.